on My name is Oluwatosin Olabode. I will be moderating today's discussion on fertility preservation, the ultimate backup plan. This webinar is brought to you by Clearview Hospital and Fertility. It is a mother and child hospital providing outstanding medical care and fertility treatment. So joining us today is Dr. Jai. He's a consultant gynecologist and fertility expert. He is also the medical director of Clearview Hospital and Fertility, and he has over 15 years working experience in obstetrics and gynecology. His professional interests include reproductive medicine, minimally invasive surgeries, and management of high-risk pregnancies. We are glad to have you join us today, Dr. Ajayi. You have the floor now, sir.
Thank you very much. This is already 6:10, so I think it makes sense to just start now. A lot of people are tired already. So I don't know whether my screen is visible to everyone. Hello? Hello, can you hear me?
We can hear you, sir. Yes, your skin is visible, sir.
Okay, thank you very much. Okay, thank you. So without further ado, I'll just go on to start. So my name is Kunle Ajayi, as previously introduced, and my topic today is fertility preservation, the ultimate backup plan. And this webinar is probably the last in the series of webinars we have for the year. And this particular presentation is what we actually shared at various fora, with different people, just trying to explain, what is possible within the fertility space and what we are doing and what we think the future holds for fertility. So I'll be discussing this topic under the following outlines. I'll be talking about fertility preservation, the reasons why we need fertility preservation, fertility options for females, fertility options for males. We'll look at ethical considerations, give some recommendations, and then conclude. I'm hoping we'll be done in about 30 to 45 minutes so that we can take questions. I'm also aware that part of the audience, many of them are not medical, so we'll try to make the presentation as down to earth as possible so that everybody that has joined us will understand what we are talking about, okay? So when we say fertility preservation, what it means is that we are trying to save eggs, sperms, or embryos for the future. So we are trying to save those things for future use. And initially it was designed to help cancer patients, because we know that people that have cancer and have treatment for the cancer may end up losing fertility. I think it's about 30% of them that will become infertile. So the idea was to see how we could save this reproductive material in such a way, the gametes and the embryo in such a way that they can be used in the future. But we found out that it's also useful in women who have decided to delay pregnancy for one reason or the other. It could be because they are busy career women. It could also be because they've not found the right partner and they're waiting. It could be because of other things. So a lot of women have decided for social reasons to opt for freezing their eggs, and it's something that has really, kicked off over the years. So because there have been massive improvements in the management of cancer patients, and then because many of them survive, it is actually quite important that we discuss future fertility with these people and the option of being able to freeze their sperm or their eggs or their embryos as it may apply, so that if when they get better and they now decide that they want to achieve pregnancy, we should be able to do it. And then healthcare workers, doctors, nurses, and everybody managing these patients should also be aware that these options exist and they should be able to offer those things to their patients. So there is this trend nowadays for people to delay fertility, and it's not um, sometimes it's not even due to any fault of anyone. It's just because women want to still go to school, they have career goals, they are pursuing higher education. There may even be financial constraints, so maybe they have student loans and housing costs and things like that. They feel that having a baby now might not be the issue, and then um, people want to travel, they want to enjoy their independence for a while, they don't want anything to hold them down, and then sometimes even they might say they just want to wait for one reason or the other. So all those reasons could be why many women are deciding that they, not even many people are actually deciding to for that option of um, um, fertility preservation. So, like I mentioned earlier, the indications and the things that will make you want to do it will include cancer and its treatment, aging. So, if a woman grows to a particular, she feels that she's got to a particular age where it might become more difficult to conceive naturally, freezing eggs might be an indication. Where we notice that there is polycystic ovarian syndrome, it could also be an indication. People with PCOS actually are able to give us a good number of eggs. Primary ovarian insufficiency is also one of the reasons why you want to freeze eggs. And it can, when I say that, what it means is, attaining menopause before the age of 40. And in those kind of people, by the time you are doing your tests and noticing that the some hormones are, like FSH are high, and then AMH, which is the one of the tests for testing ovarian reserve, is low, then you might need to freeze eggs just in case of. And then there's a new trend, where people decide to freeze their gametes when they're undergoing transgender treatment. That has not really taken off in Nigeria. But if, for example, a male wants to become female, it might be advisable for that male to freeze his sperm or before undergoing gender assignment surgery. Or the other way around, is a woman that wants to become a man, same thing applies. That has not really taken off here, but I just thought to put that there because it could be one of the indications for treatment. For cancer, treatment could be surgery, it could be chemotherapy, it could be radiotherapy. Any of those treatment modalities can actually cause infertility. So in males who have testicular cancer, bladder cancer, prostate cancer, or rectal cancer, the surgery on any of those things can actually lead to loss of testicular tissue and loss of testicular function, and they might become infertile due to that. For females, cervical cancer, endometrial cancer, ovarian cancer, most of them will require surgery, radiotherapy and chemotherapy. Any of those modalities would Probably, in fact, with cervical cancer, for example, you might need to remove both ovaries as part of the treatment. Endometrial cancer, same thing. Ovarian cancer, but that goes without saying. If the ovaries are involved in cancer, you might need to remove it. And you know, the ovaries are the things that carry the eggs. Once the ovaries are gone, there are no eggs anymore. So if it's possible to retrieve eggs in such instances, we might do that. Chemotherapy just means using medication like drugs to kill cancer cells. And we noticed that some of these drugs are more harmful to the gametes than others. Some of them are called alkylating agents, they're older agents, and there are some newer ones. So the older ones tend to actually cause more problems than the newer ones. If you use a single agent compared to a double agent, single agent chemotherapy has less effect on reproduction than double agent. And if the dose is high, it can cause more problems. If then age also, if the chemotherapy is carried out in somebody who has not attained puberty, because the eggs are in resting state, the effect is much lower. But if it is done in somebody who has achieved puberty and then undergoing all the cycling that you see, there's always that possibility that chemotherapy will affect them. Same thing with radiotherapy, same thing with surgery. And the reason why this is so bad is because women are usually born with a fixed number of eggs. That's the way to explain this. So a woman is born with a fixed number, and by the time before she gets to menarche, which is the beginning of menses, they're in a resting state, nothing happens. But by the time they enter into puberty, the ovaries start functioning the way they should, and the eggs get produced. Every month, about 15 or 20 eggs are released, are recruited, not released, they're recruited. But when one of them becomes dominant, it suppresses the others, and only one egg usually is released at the end of the day. So if, as a woman grows older, so imagine losing 15 to 20 eggs every cycle. As she grows older, the ovarian reserve, or the number of eggs within the ovaries, reduce, significantly. So that's why I said that, as a woman grows older, the effect of chemotherapy or radiotherapy tend to be higher compared to those ones who are much younger. So keep that in mind as we go on, so that we can explain this. This is just a graph showing you what happens to ovarian reserve. So before the person is born, the value is as almost in the millions, but by the time she gets to about say 30, it will have gone to maybe just a few thousands. So that needs to be put in mind. And then, like I said earlier, some particular agents, I don't want to start mentioning their names, because like I said, there are some people here who are non-doctors. Just know that some drugs actually have more effects on the ovary than others, okay? Same to radiotherapy, and then for radiotherapy, which is the use of radiation to manage patients. Radiation, the dose of radiation actually matters. If you use a high dose, there's that risk that you might make that person sterile, whether male or female. The same thing, goes for this. So in aging, like I said earlier, women are born with a fixed number of eggs. So as you grow older, the reproductive potential drops significantly. And the number of eggs that are available for use every month also reduce. So if then the quality would also reduce as we grow older to from 35. So it might actually make sense to think of preserving your eggs or your sperm or your eggs most significantly as you grow older, because we found out that women who are older, even when they have children, also have a higher of birth defects. And of course, you wouldn't, I mean, why would you want to struggle and have a baby and then end up a child that will require special needs and attention? So a lot of people actually say that there's nothing like a menopause, but the truth is that men will also get to a particular age where their sperms no longer function the way they should. It's not as bad as what you see in women, but it's also something that is becoming more obvious to every one of us now. So age is a big issue. And because of that, fertility preservation might be an option. I've mentioned PCOS before. PCOS is a big issue, and it is the most common type of endocrine disorder in women. And it can actually predispose women to having type 2 diabetes, endometrial hyperplasia, endometrial cancer, and things like that. And when there is PCOS, many of the women don't ovulate. If they don't ovulate, they can't produce eggs. There's no egg for fertilization, and if there's no fertilization, there will be no pregnancy. So when they come in and they seek treatment for fertility, like ovulation induction, we tend to get a lot of eggs from them. So instead of discarding those eggs, we can actually have them frozen for future use, because patients with PCOS also tend to be a bit more receptive to many of the drugs we give for IVF. And if you're not careful, you might even tip them into something called hyperstimulation. So there's a fine balance between normal and hyperstimulation. So we just need to be very, very careful when doing that. Okay. So PCOS is one of the conditions in which you can decide to freeze eggs. And then primary ovarian insufficiency, like I mentioned before, is like getting menopause before the age of 40. It's also known as premature ovarian failure. And what happens is that estrogen levels drop, and the person just goes into like what you see in a woman who is in menopause. The estrogen drops, they can't get pregnant, and there's a risk of bone loss and heart problems like you see in menopausal women. And so if the diagnosis is made before total shutdown of the ovaries, one can actually decide to freeze the eggs, before that time. Okay? So I mentioned this before, like I said, in passing, just because, like I said, it's not something that's happening in Nigeria yet. I don't know whether it will ever be a thing, but it's something that is happening in other clients. So, and it's something that we all need to be aware of. So men and women who decide to change their genders usually would also freeze their gametes just in case. Okay, we will take questions after the whole presentation. And like I said, I'm trying to just do 30 minutes because I know it's late in the day and I don't want to waste your time. Okay, so what are the options that are available for females? So a woman comes to us and she wants to, she wants fertility preservation. These 5 things are the things that are possible. So we can actually do hormonal protection. I will explain all that. We could do ovarian transposition. We could freeze embryos. We could freeze eggs, and we could freeze ovarian tissue. So those are things that are possible in today's climate. All those things that I've mentioned are possible. So I want to explain by saying that the first one is, because I told you earlier that women who are younger also don't have plenty problems when it comes to chemotherapy or radiotherapy because their ovaries are in a resting state. So we can actually give hormones to sort of suppress the ovaries and keep them in a resting state while giving chemotherapy and all those things. That way, the effect of the chemotherapy or radiotherapy is reduced, and the risk of infertility is also reduced. Okay, and there are a number of agents that we use. They fall under a class called GnRH analogs, and this particular treatment option is reserved for some people who are undergoing chemotherapy or chemoradiation. For ovarian transposition, what we are trying to do is to move the ovary away from the pelvis. So if a woman is about to undergo something like radiotherapy to the pelvis due to one form of cancer or the other, we could actually take the ovary away from the pelvis and implant it outside. I'll show you pictures later. And it is useful for those ones undergoing chemotherapy. So we mobilize the ovary by laparoscopy. We clip it somewhere out of the pelvis, allow treatment to go on, and then later we can put it back in this position. And that helps to, preserve the ovary, and of course later make it possible for fertility to occur. The only problem with it is that you can only use it. That's the picture. You can't use it for someone who, for example, is having chemo, because remember that chemo is usually intravenous or oral, and that one travels through the whole system. So moving the ovary away from the pelvis will not solve the problem. But to work for somebody who is only having the radiotherapy. And the other risk is that if there is problem in the ovary itself, the risk of transferring cancer cells to other places is high. So these are some of the risks of that transposition I mentioned. But with careful handling and proper surgical techniques and proper assessment, because you need to be sure that whatever ovary you are moving doesn't have cancer cells in it. If you're able to do all that, then we'll be fine. But if the woman is going to undergo IVF and we need to retrieve the eggs, we might need to return the ovary back to its former position, or else we won't be able to get to where the ovaries are. Other complications could be chronic pelvic pain, adhesions, and other things. Premature ovarian failure could happen because we could cut off the blood supply, but it is not a very common occurrence if done by the right person. Like I said, it's usually done with laparoscopy. So, in fact, there's a minimal or no scar at the end of the day. Okay, so that's that. So the one that most people are aware of is where we freeze embryos. Embryos are the results of uniting both the sperm and the egg. It is what we do in IVF. IVF basically is a way of generating embryos, in the lab. And what we do is to put the egg and the sperm together, either during conventional IVF or injecting the sperm into the egg. And in that process, we're able to generate embryos. And then when they grow up to maybe 3 days or 5 days, we can freeze them. So this is an established technology. Everybody knows about it. It's been in existence for a very long time. And I think the first IVF baby was born in 1978. So that means she'll be 40-something, maybe 46 or so. So it's well-proven technology. So what happens now is that once embryos are generated, they can be frozen. And studies have shown that frozen embryos, don't cause problems. The risk of abnormality is not different from if you use fresh embryos. Success rates in IVF sometimes might even be higher when you use frozen embryos than if you use fresh embryos. So those are some of the things that we've seen. So freezing embryos has been shown to be safe. And cumulative live birth rates, ongoing pregnancy rates, and all that are the same between oncologic, people that have had cancer treatment, and people who have not had cancer treatment. So it is a well-established way of preserving fertility, and it's available in Nigeria as well as in other countries around. Okay. The problem with embryos, cryopreservation of embryos, is that the woman would need to have a partner. So she would probably need, or she would need to have donor sperm. So what it doesn't allow for autonomy, you know. If a woman decides that she doesn't even want to have children anymore, and her partner says he wants to have children, having embryos might create a legal issue. When we're talking about the ethical part of this whole thing, we will still talk about that. This is a process of IVF. It just shows you what we do. So we, of course, stimulate, and then we stimulate means using medications to make the woman produce a lot of eggs. We will retrieve the eggs, you know, through the vagina using a needle. After we retrieve the eggs, we mix them together in the lab, like I said earlier, generate embryos, and we can transfer the embryo immediately, or we can freeze. But since we're talking about cryopreservation today, there's a freezing part, and we use a technology called vitrification. Vitrification has been shown to be very, very good, and it helps you get a high yield when you thaw the embryos. The embryos tend to do better when you do vitrification as compared to the old way of doing it, which is called, that one is slow freezing. Slow freezing causes some damage in the cells that, you know, and many of the eggs might not even recover. But with the kind of thing we do now, vitrification is the way to go. So what are the limits of embryo freezing? It takes about 2 weeks, you know, and it might actually delay treatment, you know, because like I said, you have to give medications to make the woman produce love. It's not something that happens in one day. It takes time, okay? And for women who have estrogen-sensitive tumors like cancers of the breast, cancer of the endometrium, the high levels of estrogen that you get with all the eggs might actually worsen the situation. I talked about partner or donor sperm required. So with that, it limits future reproductive autonomy. And you can, of course, you cannot use this in girls who have not achieved puberty. You can't use, because you can't even get any egg in a woman who don't have puberty. So it's not, that's one of the limitations of embryo cryopreservation. Okay. So the next one, the one that a lot of people are talking about now is egg freezing. And with egg freezing, the process is similar. The process of stimulation and collection is the same as embryo freezing. The only thing you won't do is that you will not inject the sperm. So you're only collecting the eggs. You are stripping you collect the eggs, you will strip the tumulus, that's whatever's covering the egg, and then check which one is positive and which one is mature and which one is not mature. So the mature oocytes, the mature eggs that we freeze, okay? And for many women who want to maintain their reproductive autonomy, this is actually the way to go. And it means that you don't need any man to tell you what to do with your eggs. It's your egg. You can decide which man you even want later in life, when you are much better, that you want to, you know, fertilize that egg. You might even decide you don't want to know which, I just want to use a donor. So it gives you a lot of options as a woman, you know, when you do oocyte cryopreservation. And like I said earlier, due to the improved freezing and thawing techniques, pregnancy rates with frozen eggs are similar to what you see, whether with fresh eggs. So there are a lot of advantages to freezing, and it doesn't. There disadvantages are, I mean, are very, very few. Okay, so that is that. Limitations, it cannot be performed on pubertal girls like embryo, like I said earlier. If a man is not in puberty yet, you won't get any eggs. So there's no point even going that way. And only a limited number of eggs can be collected in one attempt. So sometimes you might need to collect like 2 or 3 times to be able to get the number of eggs that you need to generate embryos. Okay. And if you cannot collect a good number of, especially with those ones that have cancer, it might restrict the number of attempts that you have for pregnancy. So ovarian tissue freezing is not available yet in Nigeria, but it's something that people also do, and it's actually one of the few options that are available to young girls, especially those ones who have not undergone puberty. So you can collect the tissue of the ovary, freeze it, let them have their treatments, and then they can always come back, later to have the ovaries transplanted back into them. And the lot of pregnancies have actually been reported with this particular technique. The problem is not that we can't retrieve the ovarian tissue. The problem is being able to process it and to make it useful for the future. But I'm sure, I'm guessing that within the next few years, there will be a center of excellence, may even be our center, where we're able to do this and cryopreserve. But so keep your fingers crossed. It's one of those things that we are really thinking about, okay? So for ovarian tissue transplantation, it means that sometimes IVF is necessary because, of course, the ovaries are, if the ovaries are transplanted in a place outside of the pelvis, IVF is necessary. If you transplant it back into the pelvis, the women can actually have normal pregnancies. And the first live birth from this kind of technique was reported in Estonia in 2014. But quite a number of other ones have been reported. Let me just put it that way. We will update these slides later. These are some of the things you would need to do. I mean, these are like prerequisites for any patient undergoing ovarian tissue freezing. So all this long list must be adhered to before you go ahead to do whatever it is you need to do. So if those prerequisites are not met, then there's no point going ahead. For the men, sperm freezing is the way to go. And of course, because men are so easy, the easiest way for us to retrieve the sperm is by masturbation. That's the easiest way, even though some of them can also be collected by sexual intercourse. But the best way is by masturbation, so that nothing is spilled. For men who are unable to achieve erection or sustain an erection or ejaculate, or we can actually retrieve the sperm surgically. And there are different methods that are available. Those are the 1, 2, 3 that you see there. So testicular biopsy, testicular sperm extraction, or epididymal aspiration of sperm, those are all possibilities. And the sperm collection is best done before treatment is commenced. So the man can actually come several times to produce sperm that we can freeze. So we can freeze several vials for him before he goes for his treatment. Okay, and of course, if you take the sperm while the man is on treatment, there's always that risk that the chemotherapy or radiotherapy would have affected, the cells, and the DNA could have been, impaired one way or the other, and that could lead to abnormalities in the offspring. Okay, so I've talked about monogonal protection before. It's the same thing, just putting the testes in a resting state before starting treatment. One could also shield the gonads, use lead sheets to cover the testes while treatment is going on. And then some people have talked about removing testicular tissue. The same way we freeze ovarian tissue, collect testicular tissue, freeze, and then transplant later after they've had treatment. The problem with that is that it's still in the experimental stage, and I'm not sure that any pregnancy has been reported yet. So that's that with the men. So a lot of people usually ask us, I mean, for how long would cryopreserved biological material be viable? We know now that eggs, sperm, and embryos can be frozen for an indefinite number of years. And I'm not sure if there is any regulation yet as per the number of years we can freeze in Nigeria. But in some other countries, I think 30 years is the upper limit. There have been babies that have been born, several years after, egg freezing, sperm freezing, or embryo freezing. And there was the popular reported case where some child was born about 30 years after the twin was born. That was sometime last year. And that turned out to be a normal baby. So freezing of gametes or embryos has not been shown to actually cause chromosomal anomalies. So even though we know that every pregnancy has that risk, the background risk is there for every pregnancy, whether IVF or whether it's natural, whether you're using frozen gametes or frozen embryos, whether you're using fresh, but all the studies that have been done so far have not really shown any significant difference in outcome, whether you use frozen material or whether you use fresh material. So the next question is, will the freezing and thawing process affect the quality and function of cells and tissue? It's not impossible. Sometimes we see that even if we freeze 10 embryos, for example, not all of them come out of thaw, come out of freezing. Then none of them will not even expand as well as we want, But once they come out of thaw well, they tend to perform like every other cell or tissue. Is it safe to use them? I've mentioned that before. Yes, they are very, very safe to use, And I would say that it is ethical to let people know that there are options, available to them. We shouldn't keep information away from patients because we think that they are dying. Not all cancer patients die. And they will ask questions later. Why wasn't I given the option of being able to freeze my sperm, freeze my egg, or I even consider freezing embryos? So we have that moral obligation as healthcare workers to let people know that those options exist. And the technology has advanced to such a level that people have achieved pregnancies and have had babies using these techniques. So the real ethic is to provide the best available information about fertility preservation, so people are able to make informed decisions. And then remember that everybody has the right to procreate. That's everybody's reproductive rights. So let's encourage them and let them know that all these things exist, And of course, while we are doing that, we should also make sure that we don't do any harm, and that whatever it is we are doing will be beneficial to that patient. So, for example, if a 50-year-old woman comes and says she wants to freeze her eggs now, I'm not sure that there's any But any reproductive health expert in his right senses who would allow that, or who would, and even no matter how much money you are being offered, because you know that you will not get any egg from that person. So we need to be guided by ethics, For young women in their 30s, even early 40s, who have expressed a desire to, delay fertility for one reason or the other, those are all good candidates for this kind of technology. And like I said earlier, they are available here in Nigeria, and they've been shown to be safe. Okay. So we must always counsel the patients about the availability of this technology. We should individualize our recommendations because not every form of fertility preservation works for everybody. So we need to individualize the treatment and make sure that we do no harm in the process. Okay, so that's that. In conclusion, uh, there have been significant advances in fertility and fertility preservation. And our patients need to be properly advised that all these techniques are available and they are safe. And I would encourage everybody listening to also help us pass on the gospel that people that want to freeze their eggs or their embryo or their sperm or anything, the technology is available here in Nigeria and it is safe. Thank you very much for listening. And then we can take questions.
Thank you very much, Dr. Ajayi, for the exciting and educating session. We thank you for sharing from your wealth of knowledge. Thank you, sir. So we'll be taking your questions now. If you have any questions, you can drop it in the chat box or you can raise your hand to indicate that you have a question.
Somebody's hands were up throughout the presentation.
Oh, okay. Okay, can we have that person?
No, I think he just said something now about says here.
Okay.
So that was Mike Demola, and he said the presentation was quite succinct. So thank you very much.
Do we have questions?
I'm trying to see whether we have questions. Yeah. Okay. So I'm just trying to see whether people have put their questions up. Okay, there's a question from someone. It says, for a lady who is not yet married, at what age is best to freeze her eggs to avoid age-related ovarian failure? No, I don't think there is really any age limit, for anybody who intends to freeze their eggs, except for a young lady. But I would say that I wouldn't delay egg freezing till I'm, say, older than 44. But I know that we can retrieve eggs from women up to that age. In fact, the regulation in Nigeria now, I think, is 44 as an upper limit for even stimulating anyone to collect eggs. So I think that would be a good guide. But if you are able to do it earlier, then I'll suggest to do it earlier, because if you are less than 35 while freezing your eggs, the risk of aneuploidy is where the child has anomalies like Down syndrome and all those other syndromes. The risk is much higher when you are older than when you are younger. So if you can freeze when you are younger, it's better. The quality is better. We get more numbers, and we're able to get even better quality embryos that we can freeze for the future. So that is the thing. Cost implication is also was also a question here, and I have to say that because it involves the use of expensive medications, expensive lab equipment, expensive media, expensive everything. It's not very cheap. But I mean, compared to other parts of the world, if you freeze your eggs in Nigeria, you are probably getting it at the bargain, you know? So that for me is a good thing. Hmm? And of course, a lot of people will worry about NEPA. And with the way NEPA is, why would how do we how are we sure that whatever we freeze would be
New
would be safe?
frozen.
Yeah. So what we usually would do is, of course, we know that we don't use NEPA. It's liquid nitrogen, and liquid nitrogen actually freezes um, the material to minus 200 and something degrees. So we don't need NEPA at all for the process of freezing. Someone is asking, is there a high risk occupation that could impact health and fertility? Yes, there are. And there are those occupations that expose you to things like chemicals and radiation. So people that work with X-rays, or work in X-ray facilities are actually at high risk of having fertility issues. And then if you work with some chemicals, that you use for different things, I don't even know their names now, but there are occupations that could actually impact your health and fertility. So one will need to be very, very careful, you know. I don't know if there are other questions. Okay. Um, so I think the presentation was very clear because we are not getting too many questions. So, and I hope I was able to answer that question by Jennifer. So thank you very much for all those of you that joined us. And this has been a long time coming. Uh, I'm very grateful for the opportunity to be able to give this talk again. Um, it's almost 7 o'clock now, so I'll